Hello, I am Louis Teboul from Paris, France, and I'm very honored to participate in this virtual ISICEM 2020. And my goal now is to try to convince you that combining fluids and vasopressors makes a lot of sense in the early phase of septic shock. My conflicts of interest are on this slide. First, I would like to remind you what are the effects of fluid infusion and of vasopressors on hemodynamics. First, the effects of fluid infusion. Fluid infusion should increase the mean systemic pressure. You probably remember the Guyton's model. This is a venous return curve with venous return on the y-axis and right atrial pressure on the x-axis. As you know, the pressure which is at zero flow, zero venous return, is called the mean systemic pressure. The mean systemic pressure is therefore the upstream pressure for venous return. And it depends on blood volume and venous tone. Interestingly, fluid infusion increases the mean systemic pressure. This is a demonstration in this study with Laurent Guérin, Xavier Monet, and others of my institution. We gave fluids to patients with shock, and in case of pleural responsiveness as well as in case of pleural unresponsiveness, in both cases, the mean systemic pressure increases. There is a shift towards the right of the venous return curve. So in any case, fluid infusion should increase the mean systemic pressure. But venous return and cardiac output should increase in pleural responsive patients only. And again, in this study, we looked at the pressure gradient for venous return, that is to say, the difference between the mean systemic pressure, the upstream pressure for venous return, and the CVP, the downstream pressure for venous return, as you can observe only in fluid responders, that is to say, in patients who will increase cardiac output in response to fluid infusion. Only in this population of patients, the pressure gradient increased. In the other patients, there is no change in the pressure gradient. So cardiac output increases only in fluid responders. And this is associated with a decrease in the systemic vascular resistance, SVR, because of the decreased sympathetic reaction, which is normally induced by low cardiac output, and also by the decreased flow-dependent vasodilation, which is normally induced by NO secretion. So therefore, SVR should decrease in case of increasing cardiac output after fluid administration. And this is well illustrated by this paper from the team of Mauricio Cecconi, and they looked at the effect of volume expansion in pleural responders, patients who increase cardiac output after volume expansion, and pleural non-responders. As you can observe, SVR decreased only in patients who increase their cardiac output after fluid infusion. So SVR decreases. What about MAP? MAP can increase only if the increase in cardiac output exceeds the decrease in systemic vascular resistance. So it is not always the case, of course. Now, what about the effects of vasopressors and mainly norepinephrine on hemodynamics? I would say, by definition, SVR increases with norepinephrine because of the vasoconstrictive effects of norepinephrine, and MAP increases with norepinephrine. But interestingly, at the same time, the mean systemic pressure also increases with norepinephrine. And this is what we observed in this study with Romain Persicchini, Xavier Monet, and others. We tried to estimate the mean systemic pressure in patients who receive mechanical ventilation, and we use the occlusion maneuvers to estimate the mean systemic pressure. And we observed that in septic shock patients, the highest dose of norepinephrine was associated with the highest mean systemic pressure compared to the lowest dose of norepinephrine. And also cardiac index increased with the highest dose of norepinephrine. So therefore, in spite of an increase in venous resistance, venous return increases with norepinephrine through an increase in the mean systemic pressure. And this is probably related to blood redistribution from unstressed to stressed volume. And this is fine because unstressed volume are normally increased during sepsis and can be overfilled by further fluid loading. So the combination of norepinephrine and with fluid can be beneficial for this increase in the mean systemic pressure. This increase is associated with increase in venous return and cardiac output only in preload responsive patients again. And this is what we observe with Olfa Hamzawi and co-workers in our institution. We studied 105 patients with septic shock, and we gave norepinephrine to these patients with a very low MAP at baseline, only 54, and MAP increased to 76. It was a mercury. At the same time, stroke volume index increased with norepinephrine, and also the global diastolic volume index, which is a marker of preload, also increased with norepinephrine, and at the same time, pulse pressure variation, which is a marker of preload dependency, decreased with norepinephrine. So therefore, we concluded that norepinephrine, given at the early phase of septic shock, was associated with an increase in preload and cardiac output and a decrease in preload dependency. With Xavier Monet and others in our institution, we also studied the effects of norepinephrine on hemodynamics in patients with very low MAP at baseline, only 49. And when we gave norepinephrine, MAP increased, but also cardiac index increased, and all the markers of preload, CVP, left ventricular endotheliuria, global and stroke volume increased with norepinephrine. So again, we found that norepinephrine was able to increase preload and cardiac output. So the messages of these two studies were that norepinephrine increases cardiac preload, increases cardiac output in preload-dependent patients, and reduced the degree of preload dependency, exactly as fluid infusion does, exactly the same effects. So if now we combine fluid infusion and norepinephrine, we should have a large increase in the mean systemic pressure, which can result in an increase in cardiac output in preload responsive patients. But at the same time, we could have an increase in the systemic vascular resistance and an increase in MAP, and therefore we can correct hypotension in patients with shock. So the potential advantages of the combination of fluids and norepinephrine is first to increase the mean systemic pressure more than fluid alone, resulting in a better cardiac output. And this is what we address in a recent study, which is presented here as an abstract, and it was presented at the ISICEM meeting last year. And we gave volume to patients with septic shock, and we estimated the mean systemic pressure using the occlusion maneuvers in patients receiving mechanical ventilation. And we observed that this increase in mean systemic pressure was larger in patients when they received norepinephrine than when they did not receive norepinephrine. So again, a synergistic effects on the mean systemic pressure of fluid plus norepinephrine. The second advantage is to correct hypotension better than fluid alone, because again, fluid alone not always increases MAP and not always corrects hypotension. The third advantage is very important. It can limit fluid overload. You know that fluid overload is very harmful. You know this study by Jean-Louis Vincent and co-workers showing that the positive cumulative fluid balance in patients with sepsis is an independent factor associated with mortality, and many other studies confirm this result. This is a study by Paul Merrick, including 25,000 patients, and showing that patients who receive more than 6 liters of fluid the first day had a higher mortality rate than the predicted one. So again, accumulation of fluid is harmful. And this is possible to reduce this accumulation of fluids by giving norepinephrine very early. This is a study we did with Gustavo Spina, Tascon, and others, where we compare the resuscitation fluids in patients who receive very early norepinephrine within the first hour after the first resuscitative fluid load compared to delayed norepinephrine, and there was less volume of fluids when we give early. The fourth advantage is to produce less hemodilution than fluid alone, and this can result in a better oxygen delivery. We know that fluid infusion can create hemodilution, can reduce hemoglobin concentration, as we showed in this study published some years ago with Xavier Mona and co-workers in our institution. Therefore, in fluid non-responders, where cardiac output does not change, we could have a decrease in oxygen delivery. Only in responders, we can have an increase in oxygen delivery. But if we give norepinephrine at the same time, we can have a better oxygen delivery because we can increase more cardiac output, and also the redistribution of blood towards the stress volume is made by blood and not by only plasma. So we have an increase in oxygen delivery. And the fifth advantage is that this combination may improve outcome. It is very important. In this study with Gustavo Espina-Tescon, we showed that the very early administration of norepinephrine was associated with a decreased cumulative mortality. But it was a retrospective study. In this prospective randomized controlled trial, monocentric trial in Thailand, showed that was a group of patients who received norepinephrine early had a higher shock control rate compared to the standard treatment. And this was the primary outcome of this study. So good result with early norepinephrine administration and with less cardiogenic pulmonary edema and less new onset of cardiac arrhythmia. So many beneficial effects. And this meta-analysis, recently published in Critical Care, showed that the early administration of norepinephrine compared to delayed was associated with decreased short-term mortality. So the experts of the ISICEM recently proposed some recommendations published in Annals of Intensive Care. And one of the recommendations is to start vasopressors, namely norepinephrine, early before completion of fluid resuscitation. So my conclusion is that the combination of fluids and norepinephrine at the early phase of septic shock can increase the mean seismic pressure more than fluid alone, resulting in a better cardiac output, can correct hypotension better than fluid alone, can limit fluid overload with less tissue edema, can produce less hemodilution than fluid alone, and may improve outcome. And this is very valuable in shock with hypovolemic plus vasodilatory components such as septic shock and some forms of hemorrhagic shock. Thank you very much for your attention.